Dr. McLean, I can hear you just fine.
Okay, sounds good.
Right. Well, welcome everyone to today's webinar sponsored by the New York City Prevention Training Center regarding the ongoing drug shortage of long-acting Bicillin, which is the only recommended regimen for pregnant patients diagnosed with syphilis and also critical to the management of infants with congenital syphilis. Just a few housekeeping things before we begin. We are recording today's webinar. We will also send out information for CME and CNE after today's webinar. And we do want to say that we have a wonderful panel of presenters here today to provide information on the context of the shortage, both at the national level and local and New York City level, review recommendations for conservation and syphilis management amidst the shortage, share clinical experiences and considerations in implementing these recommendations, and to provide helpful information regarding management with alternative regimens, including doxycycline as well as lenticillin. We do have 4 presenters with us today. At the end of presentations, we will take questions. So if you have any questions during the webinar, please place them in the Q&A box and not the chat. But we will begin today with Dr. Preeti Pathela. Dr. Pathela is the Executive Director of the STI program in the Bureau of Hepatitis, HIV, and STI at the New York City Department of Health and Mental Hygiene. She has overall responsibility for directing, evaluating, and coordinating the activities of the program, which consists of roughly 85 staff who conduct work in STI programs. She also serves as president-elect of the American STD Association's Board of Directors and as an associate editor of the Journal of Sexually Transmitted Diseases. Welcome, Dr. Pathela.
Thank you so much. I know that I need to change something here, which
Actually, your slides look good.
Oh,
Okay.
I have full screen up? Okay.
Yes, that
Good.
looks
Thank
good.
you.
Mhm.
Okay. All right. Well, good afternoon, everybody. I'm so happy to be here to provide some context about syphilis in New York City. I'm going to zoom out first, though, to talk about syphilis rates nationwide. And this is a graph of syphilis in the United States going back all the way to 1941. And you can see here we had at that time a very, very high rate of syphilis, approaching 500 per 100,000 population. And then with the advent of penicillin and targeted interventions, we brought that rate down so that it hit its lowest point in the late 90s when it was announced that the US was on the verge of syphilis elimination. And we've had increases since that time that don't seem that impressive given the scale of this graph, but were attributed to a number of factors, including great advances in HIV interventions, which of course was wonderful for HIV prevention, but didn't do so much in terms of the prevention of other STIs that affect overlapping at-risk populations, suboptimal provider knowledge about syphilis, because again, it really wasn't on the radar for the longest time. And so there's a lack of knowledge about symptom recognition and best practices around screening and treatment. And then behavioral factors having to do with decreasing condom use at the population level, increasing use of apps for dating and hookups, increasing reports of anonymous partners, which makes contact tracing and disease intervention especially difficult. And then more recreational drug use and structural vulnerabilities that include things like housing instability, barriers to healthcare access, and poor mental health status, all of which are related to STI transmission. Here now are the rates that we saw in New York City going back 25 years, and this is for primary and secondary syphilis. And you can see here the case rate increases dramatically among people who reported to the health department as male. So that it reached a peak in 2022 of 50 per 100,000. And then we have a sharp drop since that time, believed to be largely associated with the availability and uptake of doxypep for STI prevention. Here now we have early latent syphilis case rates, again by reported sex, and you can see here the divergent rates by sex, and again that precipitous drop that we see among people reported to us as male. And here the case rates for late syphilis and syphilis of unknown duration, more steady rates in recent years compared with the rates that we saw for the earlier stages of syphilis, and also a substantial burden among women as well as men. For syphilis, we've seen drops. These are just showing information for 2024 versus 2023, and we've seen drops of 15% in case numbers from one year to the next. But I put this up here just to say that we still have a really high burden of disease with nearly 1,500 primary and secondary syphilis cases and 6,000 latent syphilis cases in need of treatment in 2024. And beyond that, we have other concerning issues. So we've had persistent disparities when it comes to race and ethnicity, with Black and Latino New Yorkers disproportionately affected. You can see here with the purple line on this graph that the rate among people who identify as Black is 3 times that among people who identify as white, even despite this overall decline that we've seen over the last couple of years. And then we have hotspots when it comes to the residents of reported syphilis cases. You can see with the darker shades in these graphs that we have higher morbidity in neighborhoods like Central Harlem, or sorry, Central Brooklyn, sorry, Lower Manhattan, and then Harlem and the Bronx. And very troubling trends when it comes to congenital syphilis. The red line on this graph shows the rate of primary and secondary syphilis that rapidly rose after 2017 among women. And we saw concomitant increases in syphilis cases among infants, so congenital syphilis, with a record high of 37 congenital syphilis cases in 2024. And that included one stillbirth and one other infant death, representing some of the most tragic outcomes of this disease. So long-acting penicillin and specifically Bicillin, is historically the only domestically available product composed purely of benzathine penicillin G. Bicillin is the recommended treatment and the only treatment for pregnant patients and for infants with congenital syphilis. There has been a shortage for some time now. The FDA first announced a shortage of Bicillin in April of 2023, and then that shortage was exacerbated by a recall of specific Bicillin lots in July of 2025. And then, unfortunately, Pfizer has recently extended the recovery timeline to the fourth quarter of 2027. During all of these shortages, or this long kind of prolonged time frame of shortage, CDC and different jurisdictions have advised treating non-pregnant people or patients with doxycycline to preserve the supply of Bicillin. On March 6th of 2026, the FDA announced it would allow the temporary importation of lenticillin to address the shortages of Bicillin, and you'll be hearing more about this later on in this webinar. But before that, I just wanted to touch upon a couple of different health department activities. So we are monitoring the Bicillin supply and treatment citywide a couple of different ways. So staff in our STI program have routine queries with high syphilis reporting healthcare facilities around Bicillin shortages and their efforts around conservation. We also are using citywide surveillance data to track treatment with non-recommended regimens. We put out provider communications regularly. One of them is through the Health Alert Network, which provides medical providers with up-to-date information and includes calls for action. Since the Bicillin shortage that began a few years ago, we've released several health advisories and Dear Colleague letters that outline treatment guidelines to help navigate the shortage. And our most recent one was in April of this year, and I'll be kind of going through that in more detail in just a minute. But before that, I just wanted to show you that information on tracking that we do using our surveillance data when we do have information on treatments that are being provided to patients. And so these are all the reasons for not using Bicillin going back to 2022. And you can see here that reported penicillin allergies, which is the yellow parts of this graph, have really declined. But the proportion of providers who are reporting issues with their Bicillin supply and thus not providing Bicillin as a treatment has gone up from 11% in 2022 to about 72% now. And this is the health advisory that I just mentioned that came out on April 17th. And I just want to run through kind of this longish list of recommendations that we provided in this letter. One is to prioritize VPG for populations for whom it's the only recommended treatment. And again, this includes pregnant patients with syphilis or exposure to syphilis, infants who may have congenital syphilis, people with syphilis or exposure to syphilis who are unable to take doxycycline. We say that you should treat non-pregnant adults with doxycycline. Do not use macrolide antibiotics as they're not effective in the treatment of syphilis. Refer pregnant people, patients, and patients for whom doxycycline is contraindicated to our sexual health clinics if VPG is unavailable, but please don't refer other patients there. And I'm sure you'll hear from our physician at the SHCs more recommendations on that. Consider lenticillin for treatment and contact us if your site is experiencing a shortage. There's an email address that is available in this letter and here on the screen. And we ask for the name of your facility to be able to advise on other facilities with adequate supplies where patients can be directed for treatment. And with that, I will turn it over to the next speaker. And thanks so much. Happy to take questions at the end.
Thanks so much, Dr. Pathella. We're now going to turn it over to Dr. Wahida Thomas, who is an infectious diseases physician. She joined the New York City Department of Health as a medical director for the sexual health clinics in 2017. In 2022, she led the sexual health clinic's response to MPOX and is currently serving as the executive medical director for the New York City public health clinics, which include the immunization, TB chest centers, and the sexual health clinics. So welcome, Dr. Thomas. And right now, Dr. Thomas, I do see, I think you might, yes, perfect.
Good. Thank you. Hi, everyone. I am going to be sharing a bit of our experience in the sexual health clinics on our process and implementation of Bicillin conservation measures. So to get us started, oh, did my slide advance? There. Just to share a little bit about our clinics. We have 6 sexual health clinics across 4 of the bureaus in New York City. In our clinics, we provide low cost and no cost services to everyone ages 12 and up. And the majority of our services are provided on a walk-in basis. So as you might imagine, we do have a high volume operation. The criteria that we currently have in place for Bicillin conservation is primarily aimed to preserve Bicillin for patients who are pregnant. And for other people that are not able to take doxycycline. So this includes people who have medical contraindications to doxycycline. We are also, as needed, use Bicillin for patients that are not able to tolerate or adhere a recommended doxycycline regimen. And we do have a lower threshold for patients who have a pregnant partner or patients who have primary or secondary syphilis. We're also using Bicillin for patients who already initiated a Bicillin series and need 1 or 2 more doses. And also for patients who have completed a doxycycline treatment, but there is suspected treatment failure. Next slide. And with these conservation measures, we were able to see a very significant drop on our utilization. So we had been using around 200 to 150 doses per month. And with our conservation measures, we are now down to around 30 doses per month. And mainly, we've been using Bicillin for people who are patients who are pregnant, patients that are not were not able to tolerate doxycycline, and this includes patients that report upfront that they've tried in the past to take Bicillin and they were not able to tolerate it. Also, patients who started taking Bicillin, but they came back because they were not able to tolerate it or just were missing a lot of doses. And this is really the bulk of the indications for Bicillin in the last couple of months. And as many of you are probably experiencing challenges, we've definitely had patients express their concerns and their frustration when they've been treated with Bicillin before, and a lot of these are patients that we've treated with Bicillin before, and now they come and they expect treatment with Bicillin. So, they're concerned when we instead recommend and offer doxycycline. And we've also experienced a lot of frustration for patients that are coming to our clinics, referred from their primary care doctor or someone else that's been taking care of them, and they're referred to our clinic specifically to receive Bicillin when they might not meet our prioritization criteria for Bicillin. So how have we been approaching this to try to mitigate some of the patient's concerns? So at the patient level, acknowledging patients' concerns about instead of having one dose and you're done, now they have to take a medication twice a day for multiple days. And also for some patients, for many patients, they're going to have side effects. So just acknowledging that we are, asking them to deal with a more complicated regimen. I think it's important, but we also emphasize that doxycycline works, and we've been using it for a long time to treat syphilis. We have patients that even when Bicillin is available, prefer not to have injections, and people really, don't do well with injections. So we've been using doxycycline for some of those patients or for patients who have allergies. Also very important to emphasize that adherence is the key. It works if you take it. And also reminding patients that there is going to be a monitoring process to make sure that they do respond to treatment. And then at the system level, we've also been working to communicate with our referral partners. So really encouraging facilities, if they're able to treat patients with doxycycline, that's really what's the best approach for the patient, and to only refer patients to us if their patient is not able to take or tolerate Bicillin. And then some other measures that we are in the process of putting in place. I mean, one is make sure that we've communicated with our ancillary staff that there is a Bicillin shortage, so that patients are able to ask questions and not be completely surprised when they come to see a clinician if they've already heard from others that there is a Bicillin shortage. We're also in the process of posting signage in our intake rooms and with our public health advisors. And this is really something that came from a request from our clinicians, and just really asking that there's like a more systemic approach to the Bicillin shortage so that the burden doesn't fall entirely on the clinician in having these conversations, but just having more visibility into the national shortage of Bicillin. And we are also in the process that their information is available to the public if they go onto our website and are going to be needing treatment for Bicillin, just to have additional opportunities for people to learn and be aware of the national shortage. And that is my last slide. So I'm going to stop sharing. Oh, and I just realized that I never turned my camera on.
That's okay.
Hi, everyone.
Thank you so much, Dr. Thomas. We're going to switch it over to Dr. McLean, who is an assistant professor of medicine in the Division of Infectious Disease at New York Presbyterian Columbia University Medical Center, where he completed his infectious disease fellowship, as well as additional research training devoted to HIV prevention and sexual health. He is core faculty with the New York City Prevention Training Center and provides consults via the CDC STI Clinical Consultation Network. So welcome, Dr. McLean. And Dr. McLean, I think you'll just need to share your slides and you are on mute.
Thanks so much, Gary.
Of course.
Okay. And are you able to see?
Yes, that looks great. Thank you.
Wonderful. So Dr. Thomas has already done a really excellent job outlining the main strategies for conserving our Bicillin supplies, including patient prioritization and management of expectations from patients, staff, and referring providers. And I just wanted to build on some of those topics with additional kind of operational and clinical points that can help make sure we make the best use of the long-acting penicillin that we have. And first, I just kind of briefly want to mention that if you're in an environment where you have a dedicated pharmacy or other team who's kind of in charge of ordering and stocking medications, it's really important to evaluate where you are now in terms of your medication stock, and then to plan ahead for future needs. So we're currently working with our pharmacy at NYP to monitor our stock levels and try to get ahead of future shortfalls, including arranging for additional supply, like ordering lenticillin, which you will hear about shortly. But I want to spend most of our time on some kind of brass tacks of syphilis management that I think actually can be really helpful in conserving BPG for when we really need it. And one of those things is actually the staging of syphilis and making sure that we're staging our patients appropriately. So anytime I give a syphilis talk, we always really kind of hone in on getting that really thorough history and physical exam in order to get accurate staging. In the case of primary syphilis, one of the things we always try to emphasize is to go looking for those lesions, especially in places where they might not be overtly obvious. Classic cases would be sort of inside the mouth, around the anus or vagina, places where patients might not have necessarily had kind of discomfort or thought to notice those things. Similarly, going looking for signs of secondary syphilis, aside just from that classic rash, things like the condyloma alata, those flat sort of warty growths on the exterior of typically the genitalia, or the alopecia with that sort of patchy appearance, often accompanied by things like systemic symptoms, generalized lymphadenopathy, fever, fatigue, and malaise. All of these things can help you really kind of confidently stage something clinically as either primary or secondary syphilis. And that's really important because if you can find evidence of that clinical stage of disease, you know that you can treat that patient effectively with just one single shot of benzathine penicillin G if there's someone who falls into kind of one of those priority groups, pregnant or not able to tolerate doxycycline. And so that actually kind of saves your penicillin usage by 2/3 just from making sure to get that good physical exam. And we mentioned that history is really important too, and this often really comes into play when we're thinking about trying to stage early versus late latent syphilis or syphilis of unknown duration. Oftentimes, this is something that I think doesn't get pursued so aggressively, because when the information just isn't there immediately available, it can be easier to err on the side of caution and say, hey, this person just needs their 3 doses of Bicillin to make sure that we've gotten things appropriately treated. But now that Bicillin is sort of so hard to come by, it becomes that much more important to try to get that additional information. Oftentimes, those prior serologies that help you distinguish early latent syphilis from one of those later stages. Sometimes that can mean just taking the extra time to fax out a records request from a prior provider. But in New York City, we also have the fabulous resource from our Department of Health of the New York City Syphilis Registry, where you can fax a request to one of the offices there at DOH, and they are able to find all of the serologies that were performed and submitted from within New York City over a pretty decent time period and get those back to you. And oftentimes, if you get that additional information, you're also able to say, hey, this is early infection. They've, seroconverted within a year, or they had a prior RPR titer within a year that's 4-fold lower. You can say, this is early latent syphilis. They only need that 1 dose. And then, as we're kind of talking about alternative therapies, a few of the points that were mentioned kind of revolved around doxycycline and sort of tolerance and adherence issues. I'll point out that for all of my patients that I'm treating with doxycycline, whether that be for something like syphilis or even chlamydia, or even using doxypep, I try to do a quick preamble on some ways to avoid and anticipate potential side effects. Those include taking doxycycline with a full glass of water to avoid the possibility that the pill kind of gets stuck there in the esophagus and causes a little bit of esophagitis. To tell people that if they're having some nausea, they can take doxycycline with food to help get around that. And to tell folks, especially now as the weather starts to get nice, that doxycycline can result in a little bit of additional sun sensitivity, and that making sure to get ahead of that by wearing sunscreen, covering up. All of those things can help people avoid a scenario where maybe they don't feel comfortable completing a course of doxycycline. For pregnant folks, I just wanted to point out that sometimes in this scenario too, folks will kind of err on the side of caution by giving more doses of benzathine penicillin rather than fewer. But the CDC guidance is really clear that pregnant women should be treated with the recommended penicillin regimen for their stage of infection. And so when you're able to confidently stage a patient with early syphilis, either primary, secondary, or early latent, you really can use just that 1 dose. And the other instance where I think sometimes people will start to break out the benzathine penicillin is in suspected treatment failure. And I just want to mention a couple points to kind of help avert that potential suspicion. So we suspect treatment failure when people either have a sustained rise in that RPR titer of 4-fold or more after treatments. And that really actually needs to occur and be stable over at least 2 weeks. So just that 1 RPR titer that looks higher than the initial one needs to actually be repeated 2 weeks later and have that sort of sustained elevation for it to constitute treatment failure, which again, in someone on doxy might make you reach for the BPG. Also, for people who are not having kind of the expected decrease in their RPR titers over time, I think one of the most common times that we get this consult at the Clinical Consultation Network is in instances where RPRs have just been checked a little too early, or people have kind of gotten concerned a little too early. So for primary and secondary syphilis, it's just important that we wait about 12 months. Oh, Gallery, your hand is up.
Sorry, I have no idea why. So you please ignore that.
Okay. So for primary and secondary syphilis, we want to wait for that RPR to come down by 12 months. And for latent stages of the disease, it's 24 months. So really, there's no need to get concerned if the patient is sort of clinically well, but that RPR titer just hasn't come down until we've waited that full duration of time. A couple other ways that we can kind of help avoid getting concerned by RPR titers that aren't behaving the way we would like is to repeat that RPR titer at the time of treatment start if the treatment has lagged kind of from the initial diagnosis. So you get that kind of first RPR and set of titer serologies back that confirms a syphilis infection. Patient doesn't make it back to the clinic for a week or more before starting treatment. We know that the RPR titer can actually change pretty significantly during that time, even without treatment. And so starting with an accurate titer really helps you make sure that you avoid kind of the appearance that the RPR titer didn't come down over time. Also important in terms of treatment failure to make sure that people who are taking doxy avoid taking it together with things like vitamins or supplements that have these divalent cations. That's iron, calcium, magnesium, zinc, things that can bind the drug and keep it from absorbing properly and potentially result in kind of a perceived lack of efficacy for doxycycline. Okay. And finally, for folks who are in environments where they're kind of guiding an enterprise approach to stewarding penicillin, I just wanted to give a very quick example of what we've done here at NYP. This is a little screenshot of the drug alert that went out to all staff, kind of laying out the facts of the penicillin shortage. As well as some of the things that we've done in response. One of those is requiring ID approval for BPG. And so if you try to order it right now at Columbia, you will get kind of an alert that pops up saying you need ID approval. But the important part about that is that you don't just sort of get that restricted alert, you immediately get offered alternatives. And so Dr. Thomas kind of already laid this out, but here's an example of our table for people who have different stages of syphilis or syphilis exposure, and what we're kind of now recommending as their treatment, while still keeping that column of benzathine penicillin for all stages in pregnant patients. I'll also just point out that depending on your environment, Bicillin might not be used only for treatment of syphilis. There are a couple of other use cases like group-based strep rheumatic fever prophylaxis in people with a history of that. There are other oral alternatives available there as well. And so just making sure to kind of have that information available to people if you are trying to spare Bicillin in that setting. And finally, I'd be remiss if I didn't point out that one of the best ways to reduce the need for syphilis treatment and BPG is to prevent syphilis infections altogether. And one of our most powerful tools in this arena, again, relies on doxycycline, but this time as doxypep, which is around 80% effective in preventing syphilis among groups at the highest risk. And so this is a great thing to be able to bring up with your patients, acknowledging that sometimes treatment options can be limited now. It's that much more important to double down on prevention. And finally, if you're in a sticky scenario, you're not really sure if someone might be eligible for doxycycline or trying to troubleshoot an instance in which doxycycline treatment isn't going as hoped, please feel free to reach out to us at the Clinical Consultation Network. And we're always really happy to talk folks through whatever's going on. All right. And that's me.
Thank you so much, Dr. McLean. Okay, so now we're on to our final speaker for today. Stephanie Arnold Peng is currently the Senior Director, Government Relations and Programs at the National Coalition of STD Directors, where she has led the policy team since 2011. In her current role, she is responsible for formulating strategy and providing overall leadership for the organization's public policy and federal government relations activities and selected programs, including federal policy and advocacy, state policy, and training. She is also a leading national subject matter expert on 340B STI issues. So welcome, Stephanie. Thanks so much for joining us today.
Thank you so much, Gauri. Happy to be with you. So I am not a physician, so I can't provide you the really great medical information that the previous presenters have done, but I am here to talk about processes that are available to you all right now to access syphilis treatment medication. Obviously we know as we've seen in the previous presenters, syphilis and congenital syphilis is on the rise. So even during a time of shortage for the main treatment, additional processes are available that need a little explanation, but are available to you all for accessing medication. So obviously we've already covered a lot of this, but congenital syphilis is increasing at a time when unfortunately our treatment options are decreasing. Bicillin is in shortage yet again. I feel like I've been working at NCSD since 2011. I feel like Bicillin has been in shortage more times than it has not been while I've been at NCSD. We do have lenticillin that is available, as Preeti mentioned, that this lenticillin is a medication that the company Cost Plus has imported from Portugal from a unique dispensation from the FDA. Lenticillin is not typically available in the US as it's not FDA approved, but lenticillin is currently approved by the FDA for importation during this time of shortage. There is a medical request form that Pfizer has is implemented for purchasing and not well purchasing, but also requesting Bicillin directly from the manufacturer. I will go through this a little bit. It is a process. It takes a little bit of time, and it does open up options for missed opportunities. But I think if we utilize this process in a unique way, can decrease, excuse me, the missed opportunities. So we are, as NCSD, and we are the membership organization for STD programs in state and local health departments across the country. So we have been recommending that our membership use the Pfizer medical request form to pre-stock Bicillin in their jurisdictions to ensure that they have access to medication ahead of needing it for an active patient in your jurisdiction. We did have a member jurisdiction that had a pregnant patient, excuse me, who needed Bicillin. They had been requesting Bicillin from Pfizer, and it did not get to the jurisdiction in time before the patient delivered. And so that patient was not able to complete their syphilis treatment before delivering. Which is obviously a missed opportunity that we do not want to have. So the focus is, of course, for the medical request form, and that's the link that's in the chat. The focus is for congenital syphilis prevention. And this is you're requesting a manual drop ship to you through your wholesaler. This is a confusing process, but I have helped some members go through this process with success. So here's a bit of my tips and tricks to utilize this form and to go through the dropship process directly from Pfizer. So as a note here that this process involves both Pfizer and your wholesaler, which is not how you usually purchase medication. It can be a little bit confusing. Pfizer is directly drop shipping the medication to the address placed on the form. They are shipping it from their warehouses. So there is a emergency stock that Pfizer keeps on hand that they hold back from providing to distributors. So they have some stock as like an emergency stock. So you're basically using this medical request form to request medication from their emergency stock. So Pfizer will ship to the address on the form, but you need to go through your wholesaler in order to get the money and the money to pay for the medication that you have requested. So we recommend that you include your wholesaler contact on the request. I have been recommending to our members that they include me as well, so I can help them go through the process and help get through the red tape, so to speak, to purchase the medication. And that is available to you as well if you'd like to keep me in the loop on how the requests are going. Some process specific information is most of entities do not have a Pfizer customer number. So what you'll want to put there is that you're requesting via drop ship through your wholesaler. So you'd put none, requesting drop ship via Cardinal or X wholesaler, whomever you use. You request the number of syringes you need, keeping in mind, of course, that they will be shipped to you in boxes of 10, and place a TBD under the order number, because that will be provided after you go through the process with the wholesaler. The wholesaler will create the dropship request, and that's the purchase order that will go as part of this process. Like I said, it's a process, but I have successfully helped a handful of members request additional medication directly from Pfizer to their location. And that is available to either public health entities or direct physicians as well. This is not just a public health process, but is available to any entity. So now I want to go through a process to purchase Lenticillin. So as I mentioned, Lenticillin is currently available through purchase through Cost Plus. Cost Plus is a company owned by Mark Cuban, who is importing Lenticillin, which is a syphilis treatment medication internationally. They're importing it into the United States. So you'll need to register on the Cost Plus Marketplace, which is this website here. And then you click on the register button, and there'll be a handful of questions to get you up and running in the marketplace. From once you've registered, and you can register even without wanting to purchase at that time. So if you think at any time in the next year to 2 years you'll be interested in purchasing Lenticillin from Cost Plus, I do recommend that you get set up on the Cost Plus marketplace. So you get set up, and then from there you can place orders and directly from Cost Plus. Preeti already mentioned that the last order that of Lenticillin, I think was placed from Cost Plus in March, and they're getting ready to do yet another importation in the coming weeks. So their Cost Plus is really on top of the numbers and in communication with FDA to get that special dispensation to import additional Lenticillin medication. I don't think anyone covered this yet, but the price is $30 per unit, and 1 unit of Lenticillin is my understanding is equal to 1.2 MUs of syphilis of Bicillin. And so if you're interested in replacing a 2.4 MUs injection, you need to purchase 2 units of Lenticillin. So it's $60 for a 2.4 MU equivalent for Lenticillin. And then I put this, the be advised note is if your entity needs new vendor paperwork, this is very common with public health entities. Just want to note that Cost Plus unfortunately does not have the staffing power to implement those that type of paperwork. So we have had members that have done some workarounds and partnerships with private clinics or with private entities to purchase via credit card. That is really the most direct and straightforward way for an entity to purchase Lenticillin. And then just one more process I want to mention is a 340B process that I could happily talk for hours on directly, but so I'm happy to follow up afterwards if anyone would want. But obviously, so we've seen this data previously from CDC, which is that congenital syphilis missed opportunities involve both no timely testing, but also either no treatment or inadequate treatment. So it's a challenging place to be in when have your reducing of your options for medication and for treatment of syphilis. But there is a process available to public health entities and to 340B entities, which we refer to as injectable syphilis treatment delivery, or ISTD. Some folks will colloquially refer to this as Bicillin delivery, but we refer to it as injectable syphilis treatment delivery, which is where a local or public health department provides purchase medication that they purchase to a private provider when they have it, when the public health entity has it, of course, for the timely treatment of the patient that private provider is treating. And the toolkit is here, and I believe you'll receive slides afterwards. So the toolkit has a lengthy explanation and how it follows the 340B patient definition. But I wanted to make this available to you all as well, so you know that there's some additional options when Bicillin is available that could be provided to non-340B entities. And that's just a quick slide for me for my contact information. And I think that's all for me.
Great. Thank you so much, Stephanie, and to all of our speakers today. We do want to turn it over to questions in the last 15 minutes that we have. And so just as a reminder, if you have questions, please place them in the Q&A. We do have a few questions in there for speakers, and I'll start with the first one. The FDA insert about lenticidine 1.2 million units is about 4 ml when reconstituted, meaning it's 8 ml for 2.4 million units for primary, secondary, or latent syphilis treatment. What has been a patient's experience with using lenticidine for syphilis treatment? So I'm not sure who the best person to answer that is. I'm thinking Dr. McLean.
Hey, I can sort of tell you what I have heard secondhand because we are using some of these 1.2 million unit doses at the moment, though I don't think it's lenticillin right now. The kind of typical is that people will need sort of that, or can need that extra jab. What we have now are sort of the pre-mixed syringes, so you can't kind of uh, you can't sort of make it into a more concentrated solution for injection in the typical volume. And so, yeah, no one's favorite thing is getting double the number of injections that they had hoped for. That being said, it's just kind of what we have to offer.
Okay. Great, thank you. The other question that we have is how can we pre-stock Bicillin if it's in shortage?
Yeah, so very good question. It does seem like a sort of what am I advising? It doesn't make a lot of sense given the world that we're in. But I think what we want to think about is what the drug isn't, the medication is in shortage. That is an FDA term and an FDA, like they have a definition of what is in shortage. And obviously, there's not as much Bicillin LA coming from the manufacturer to wholesalers and then to providers. But as I noted during my presentation, Pfizer does have some medication in their warehouses that they own and they get to determine how they send it out. So Bicillin is in shortage and we don't have as much as we need, but there is still Bicillin in the system and available to entities to receive through this medical request form from Pfizer. It is within Pfizer's I don't want to say right, that's not quite the right word I'm looking for, but in their purview to determine how these requests are approved or not approved. So I can't, I do not control that, so I can't guarantee that if it's used, the request as used will be approved. But as I said, I have assisted with a few members to use the form and have received medication through that form. So I hope that answers the question and makes sense. We're using a medical request form to get access to medication that exists in a place that you don't usually have access to, or you can't usually have access to the Pfizer warehouses because they own that medication. But through the medical request form, they will permit you to request it and then you purchase it.
Great, thanks so much, Stephanie. Another question, can lenticidine be reconstituted with lidocaine? Not sure who wants to take that.
I personally do actually not know the answer to that question, but would be curious to find out. Dr. Thomas?
Yeah, we have not used lenticidine in our clinics yet. And so we have no lived experience using lenticidine. From my quick lookup, you can reconstitute it with lidocaine, but I think we can circle back with specifics.
Thank you. Yes, we can definitely look into that and provide more information in an email to participants after the webinar. A few other questions. One is a bit more New York City specific, and that is how can New York City providers get lenticidine? What does this process look like?
I'll try to take that even though I'm not New York specific. I've also don't have any lived experience of purchasing lenticillin, but we have do have some members who have. But my understanding is it's a relatively straightforward process. You register on the Cost Plus marketplace and then get set up as a purchaser directly through Cost Plus. And especially if you're a private provider that's able to either or simply order with a credit card, and you can go through that process and order directly through Cost Plus. But I don't know if others have additional experience with this. But that, at least from the public health department side, the barrier previously for lenticillin has both been cost, right? It is more expensive than 340B Bicillin, which is pennies, but also getting approved for as a vendor, right? That can be approved. That can be a challenging process for public health entities, but if you're a private provider or it might be an easier process to get approved to purchase medication directly through Cost Plus and not have to go through a lengthy um, uh, process through your bureaucracy.
Thanks, Stephanie. Is there anything else to add specific to New York City on this or no? Okay. There is a comment actually in the chat that says that there's a reference listed on the National Prevention Training Center website that indicates that lenticillin is typically supplied with 1.5% Latticade. So I think that actually is the answer right there. But and another question, if an adult has doxycycline allergy, what would be the preferred treatment in your experience with good efficacy?
Yeah, in that case, if you can confirm that it is a true doxycycline allergy and can, IgE mediated, health-threatening kind of allergy, that is an indication to resort to injectable penicillin. I think oftentimes we just need to be very careful that we are making sure this is a real allergy. And folks will often report some things like GI upset as an allergy or even a rash that was actually just that sort of sun sensitivity that we discussed. And so taking the time to try to tease that out is really sort of the most important first step there before using the penicillin.
Thank you. Another question, is lenticillin covered by 340B drug pricing?
It is not, unfortunately. 340B drug pricing is only available for FDA-approved medication. It's also voluntary for the pharmaceutical entities, which is another conversation we could get into. But know that if this is just available through Cost Plus for the $60 for 2 units to make it an equivalent to 2.4. So unfortunately, it's not 340B available.
Thank you. And so more of a process question here. Can we refer patients to the New York City sexual health clinics if we are unable to treat a patient with Bicillin?
Absolutely. Patients who are in need of Bicillin and for whom doxycycline is not an option should and can be referred to our clinics. I do want to emphasize that when we receive referrals, we are gonna adhere by our current criteria for Bicillin use. So if the patient comes in and they otherwise are able and doxycycline is appropriate for them, that's what we're going to recommend. So just to help manage expectations for patients that are being referred to our clinics. But absolutely, we are that's what we're here for. We are ready, and part of our conservation measures take into account that we are going to be we want to be ready to be able to treat patients for whom doxycycline is really not an option and they need Bicillin.
Okay, thank you so much, Dr. Thomas. How would you reassure someone who's eligible for doxycycline as an alternative treatment, but reluctant to accept doxy over Bicillin?
I can share a bit. It's yeah, I mentioned in our presentation, I think it's important to acknowledge what particular concerns the patient might have. For some, is just, the inconvenience of it and, wanting to understand why we can't just, give them the option that is more convenient. And I think, you know, making folks aware that this is a national shortage and we need to prioritize, maybe prioritize is not the word because we all want to be prioritized, but we need to preserve Bicillin for patients who are uh, otherwise not able to take doxycycline. Um, that, for some folks might be a motivation. I know sometimes for patients we've offered them, like, you've never taken doxycycline before. We have a lot of patients that are able to take it, they tolerate, they complete their treatment. Let's try it. And if this is not working out for you, you can always come back and we can reassess. I think also, yeah, having them feel that this is not their last and only chance, like they can always come back and we can always, modify as needed. And we've definitely had to do that. I think we all have. I guess one other thing is just providing wider context for the use of Bicillin to treat penicillin. Like, it's not a new medication. We've been doing this for many, many years. So there's a lot of at least observational data to support the use of doxycycline. And I don't know, Dr. McLean, if you want to add.
I'll just say that, one of the consequences of these recurring shortages is that observational data continues to accumulate, maybe faster than it did before. And so that's kind of continuing to roll in and continuing to support that as an effective alternative.
Thank you both for that response. I think we have time for one more question. Does recommending people to pre-order benzathine further contribute to the shortage?
So I appreciate the question and I appreciate the instinct, right? We want to get out of this shortage as quickly as if possible. And we want to make sure that, as Dr. Thomas said, we are preserving the Bicillin that is available for pregnant patients or patients that have pregnant partners. And you're following all the guidelines that New York City has put out that I am not 100% following since I'm not a provider. But what I would say is that we in public health, we have to ensure that those who are pregnant patients have efficient access to Bicillin. It is our jobs to ensure that congenital syphilis is avoided as much as we can honestly do that. And so my recommendations is to pre-order and to pre-stock Bicillin through this medical process, so we ensure that the medication for the patients that the medication needs to be preserved for have access to the medication, if that made sense. And so I'd also note that, through the medical request form, Pfizer has the ability to monitor its own stock, and they can approve or not approve medication based on what they see as an appropriate preserving of the medication that they have available. I don't have data available of how much Bicillin Pfizer has in its own warehouses. That's private data unique to Pfizer. So I'd say that we should be encouraging the manufacturer of this medication to be a partner with us in congenital syphilis prevention and using the medical request form to pre-stock that medication so it's available for pregnant patients is the best way to do that.
Thank you, Stephanie. I appreciate that response. If panelists can stay on for one last question, that would be great. The last question is, does sending BIC to pharmacy for a patient to pick up contribute to the shortage, or how helpful is it to send BIC for pickup? Bicillin.
I'm actually not so
Not sure
sure
if
how
that
many sort
makes.
of retail. Yeah,
Mhm.
you're talking about presumably sort of like retail pharmacies, the CVS down the block. I don't think most sort of brick and mortar retail pharmacies stock something like Bicillin for patients to then pick up and have administered off-site. The drug doesn't stay good forever. It's usually really only stocked by and in the places that will use it.
Yeah, and
Thanks,
I can
Dr.
add a lot of these patients are the ones that end up coming to our sexual health clinics. They usually come in with like a write up a prescription from their clinicians. They go to the pharmacy and then from the pharmacy they recommend them to come to us. So yeah, I'm not sure if that's how feasible that is.
Well, thank you. I'd like to thank our panelists for presenting with us today. Also want to thank our audience for taking the time to attend this and for all the questions. We will send out slides as well as instructions for CME and CNE, and we hope to see you all on a future webinar. Thank you.